Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is Adrian Gropper. He is CTO of the nonprofit Patient Privacy Rights Foundation, where he is bringing to bear his MIT engineering training and his Harvard medical training, as well as his career experience as a medical device entrepreneur. That has included launching Amicus, a major radiology PACS business out of MGH. More recently, he had a paper winning a prize at the ONC's 2016 Blockchain Health Competition. His current project, HIE of One, uses public blockchain standards and open source software to enable patient-controlled, independent health records that can last a lifetime. He is active in blockchain standards development for identity, credentials, and reputation. Welcome, Adrian, and thanks for joining us today.
Thank you.
Adrian, for as long as I've known you, I think you have been focused on the notion of patient control of patient data. It seems to me that the contours of that issue may have shifted a bit over time here and there, and I'm interested to hear how you think information blocking as we currently understand it, or perhaps as it's defined in the 21st Century Cures Act, can be addressed by patient-directed exchange.
It's simply a matter of scale. We've had attempts for at least 10 years, maybe more, since the National Health Information Network term was coined, to have a way of moving patient health data from one place to another. And every single one of them, not only has it failed to catch on at any significant scale, but with each round of efforts, the new problems emerge. So it's what I would call, or what academics call, a wicked problem. It's not just a tough problem. So, to give you an example, all of the issues around patient matching that have been the subject of, again, round after round, think of it as a subcommittee or a subset of the National Health Information Sharing problem. The length of the documents, if you were to map, the conferences and the challenges and the length of the documents explaining the problem of patient matching over the 10 years, I think you would find that it is steadily increasing and hasn't yet reached an inflection point. This, I believe, is due to the fact that we've been trying to move the data around under a very inadequate, I would use the term futile, HIPAA set of regulations, where HIPAA decided to take out the right to consent a year after it was put in place. I don't know how many years ago is it now. What that means is that healthcare industry keeps looking to figure out how to take data sharing processes that are from the early days of moving from paper to digital, and move them to being nationwide and covering not just hospitals, but all of the business associates, data brokers, and now non-HIPAA covered entities on the one side, like wearables, as well as the entities that generate sensitive data under 42 CFR Part 2. And there's this idea, this crazy, I would say, idea, or futile, if not crazy, that you can do all of this without transparency and explicit consent, just because HIPAA, as it stands, allows you to do this under treatment, payment, and operations exemptions, allows you to do it under the identification, exemptions.
So we are looking at the different sorts of issues that come up and the sorts of concerns that may come up in terms of secondary uses of patient information, right? And limiting the ability of patients to limit that secondary use. I hear you speaking to that. And I guess the question is whether there is also a need for patients to be involved in mediating the exchange from one healthcare provider or system participant to another. And your comment earlier makes me think of that cartoon that talks about the need for a new standard, because we have 15 standards that we're dealing with, and the solution to the problem is going to be a new standard. But then, of course, we have 16 standards and limited adoption of all of them. So is there a solution in here? Is there a solution in here that's going to be based on something in the hands of a patient that gets us out of this problem of dealing with multiple standards and systems?
Yes, there's a very obvious solution at the sort of principle level, and then there are standards themselves, which I can talk about if you want. At the principle level, we have a model for consented, transparent, and accountable sharing of data in our everyday lives. It's how our money moves, right? We would never, ever tolerate our money, our bank accounts being tapped and used without transparency to us, without the ability to consent or authorize specific transfers, and then without holding the people that receive that money accountable through an accounting for disclosures. These three things are all missing from sort of the HIPAA treatment, payment, and operation type sharing or secondary uses, if you want to call it that. So the solution is evident in how health data moves under the release of information rules. These are the forms that we are all familiar with. They come to us from before the days of digital APIs, right? You go into the basement, you fill out this form, you tell the hospital where the data is supposed to go, and the data goes there. And there is no limitation on what data they have. There's no limitation on whether that data is going to Social Security or to a lawyer that might sue them or to North Korea. And that's just it. That's how data moves. And so we have these two examples of what I'm calling patient-directed exchange. And they are the basis for large-scale health information sharing and secondary data uses.
So there are a number of government initiatives. We touched at least briefly on the 21st Century Cures Act, and that and others are supposed to make us all feel better, I suppose, about data access and data security. There's the My Healthy Data initiative by the government recently, and there's also another one of the arrows in the quiver, so to speak, is TEFCA, the Trusted Exchange Framework and Common Agreement. And I'm wondering, what is your view on TEFCA? Does it address identity and consent issues adequately, or do you feel it's not quite ready for prime time?
As the draft was sent out, it's definitely not ready for prime time. But it is another step on what used to be called a 5-year plan or the 10-year plan. From the previous administration, it was always one of these things that it's always 10 years in the future, no matter when you look. But there is an aspect of TEFCA. So there are aspects of TEFCA which, like the 10-year plans, are all well-meaning. But there are also things in that initial draft which make almost no sense at all when you just look at them sort of cold.
So first, let me interrupt you, Adrian, and ask, can you give sort of 25 words or less, what is TEFCA? When we talk about TEFCA, what is that?
Yes, TEFCA is the Trusted Exchange Framework and Common Agreement. And the idea behind TEFCA is that if there is one regulated or regulatory entity or whatever it turns out to be that can rule them all, it will allow all the important sources of health data to adopt that common agreement. So instead of having a patchwork of regional health information exchanges and particular policies at particular health data sources, whether they be covered by HIPAA or not quite covered by HIPAA. The idea would be that Health and Human Services would establish a control relationship with a governing body that doesn't exist, and I would argue has never existed, that in turn would enforce this common agreement. So it is an example of a strategy that's kind of like a national federation, like, for instance, the federation that moves money between banks when a check clears. And that's an example of where banks just decide to agree that under the ACH rules, I think they're called, if you want to move money from one bank to the other, you go under the ACH rules, and the ACH takes a tiny, tiny cut in order to administer the common agreement. The difference between that and healthcare, which makes, again, healthcare impractical or to apply, is that banks are very uniform and very uniformly regulated institutions that handle only one kind of thing called fiduciary currency, whereas healthcare institutions covered by Pesce are as broad as human life, and the data itself is as broad as almost anything you can imagine. So this idea that you can get one agency under the control of HHS to administer a common agreement around health data is I think, interesting, but not an easy thing to govern. Now, specifically, another aspect of Pesce, which is just vague in the draft and needs to be called out, is whether patients have the right to opt in or opt out of the transfer, and in two different places in the document, right? So in other words, if you want to think of it as an opt-out, that would be under HIPAA, treatment, payment, and operations, which I said wasn't working, but the default would be that the information flows under HIPAA, I think they say explicitly, but then individuals could say, no, don't send it from here or don't send it to there. And then the alternative further down in the document is what Pesce says, that they have full control. Well, if patients have full control, then that's an opt-in system, like the release of information method that I mentioned existed since the days of paper. And Pesce, as it stands, is talking both sides of opt-in and opt-out from this perspective. And clearly that's going to have to be resolved. If Pesce moves in the direction that my blog posts and my formal comments, PPR's formal comments, go into, then they'll simply say, look, the system is going to be transparent and accountable and authorization-based, which is fully opt-in, and then there may be options for information to move under emergency break the glass type situations or whatever, where the opt-in is not required, but you still have the transparency and the accountability that we build into the HIE of One and into this patient-directed exchange strategy. And so Pesce can work, and there could be a common agreement that rules them all. But in my opinion, it would have to be very strictly in the patient-directed approach.
If you're just tuning in, this is Harlow on Healthcare, coming to you on Healthcare Now Radio. I'm David Harlow, and my guest today is Adrian Gropper. Adrian, you've written and worked on a concept of an HIE, Health Information Exchange of One, as a patient-owned technology, and have also spoken about the need for physician-owned technology as well. I wonder if you could speak about that a little bit.
Yes, thank you for the opportunity to do that. HIE of One is a open source reference implementation. It is not a commercial product, at least not now. And it is the way that a group of us including Michael Chen out in Portland. He's a family doc. That's the chief technology, the chief software developer here. It's a way that we can influence the actual standards that are involved in health information exchange, as well as contribute some understanding to the policy discussions. So the idea behind HIE of One is the same idea that you have behind your lawyer or your doctor, which is that somebody that is your agent, I want to stress this term agency, somebody that acts as your agent has a fiduciary relationship with you. You can trust them completely to represent your interests and nobody else's, because they're typically because they're licensed professionally, and their name would do mud if they didn't. So, for instance, when you go to have a relationship with a lawyer, very typically the first thing they do before they even talk to you or take your money is they run a conflict of interest check. And they at least, so they're always working under this assumption that when they take you on as your agent, as your trustee, which by the way is the name of our product, or our, yes, you could call it a product in HIE of One, before they take you on or sign on as your trustee, they establish this fiduciary relationship. Well, now what we're doing is translating this idea of a fiduciary relationship amongst the two licensed parties that are the primary way that money is spent in healthcare. $3 trillion worth of healthcare in the U.S. goes through the pen, through the order book, through the prescription pad, through the referral of a licensed physician. And in before computers, that never required any hospital or any EHR vendor to be involved or any clearinghouses at all. It was simply the physician acting as a licensed professional, as a fiduciary to the patient under the Hippocratic Oath, and the patient, of course, acting as the subject and the authorizer of whatever's going on. So if you now move this concept of agency into the uses, all of the uses of health data, whether it's clinical or research or other what you're calling secondary uses, then what we're doing with HIE of One is providing the technology, and it's standards-based and it's open source. So there's no walled garden. It's not like HIE of One is going to say, oh, here's this black box, and we know what's in it. And if you don't like our black box, go buy a black box from somebody else. But it is totally open source and totally transparent, and therefore it can act technically as your fiduciary in how your health data moves from A to B without your having to be an intermediary to that movement. So the data, just like with banking data, the money moves from bank A to bank B. It doesn't go through your wallet on its way.
So the access and control of data in the hands of the patient, or through an agent or a fiduciary of the patient, is an important issue, an important concept. Ultimately, I think we all recognize that a patient has a right to data. A patient has a right to direct where data is going in most circumstances. And this has now been recognized in a slightly unexpected area of regulation, namely the CMS payment rule under Medicare. There are now two sets of rules out there, one where the public comment period is closed and one where the comment period is open. And we expect there to be other rules as well that are essentially including an RFI, a request for information, around the issue of patient access to information, to health data, being made a condition of participation in Medicare. And in some ways, this is revolutionary. In some ways, it sort of makes a lot of sense because, as you and I have been talking about these issues for years, and many others have as well, there has been limited enforcement activity on the part of the federal government around the rules that require healthcare providers and other covered entities to provide access to patients to their own health records. And by bringing the full force and effort of the Medicare conditions of participation and that sort of enforcement framework to bear on all this, that seems to have a better chance of getting the attention of those healthcare providers that thus far may not have been paying attention or may not have been providing access as requested by patients. Do you see this as a viable pathway for enforcement of this idea?
Absolutely. And not only is it a viable pathway for shifting attention to sharing by patient-directed exchange, but we have this wonderful experiment right now, which unfortunately hasn't quite flipped to patient-directed exchange, called Blue Button 2.0. So before, even as we're talking about this patient access condition for participation, that begs the issue, what do we mean by patient access? And the issue there is whether the patient access is hobbled, whether the patient is a second-class citizen, if you would, in patient-directed exchange, or whether the patient access condition for participation is interpreted more like the release of information form that I mentioned earlier. And what we have going on right now is Medicare, CMS, has actually announced that they are supporting access to a patient's data that they have as Medicare, the explanation of benefits, if you would, which has always been available very nicely as a blue button file on their portal, and that's patient access, certainly. They've announced that they are now offering production access, or about to offer production access on the Blue Button 2.0, which is an API, which is unfortunately, and I want to stress this term, unfortunately, what they currently announce for production does not do patient-directed exchange. It interprets patient access in this sort of second-class citizenship way that would force the patient to be an intermediary, to use some kind of magical health record, personal health record, or paper, or whatever, in order to take it from here to there. And what I'm being very insistent on is to take this wonderful opportunity that the conditions of participation has opened up in this comment period, and actually apply it not to the Medicare covered, not to the Medicare hospitals, which it would, but start out with Medicare itself. In other words, Medicare should be eating its own dog food and implementing Blue Button 2.0 to be compatible with HIE of One, with dynamic client registration, refresh tokens, and this ability to use the terms of the 21st Century Cures Act. The patient should be able, and the physician, with the patient's approval and with their accountability, should be able to move data from here to there without special effort. And I don't know if we have time for me to go into the details of what without special effort looks like in the HIE of One implementation, but you could sort of very well imagine that you sign into a patient portal, or you sign into the Medicare benefits explanation portal that already exists, and you literally fill out the release of information form that you would have had as a paper document. You can get those from any hospital, even online, but you fill that out at the portal, and then the information moves. And it doesn't move through you don't have to specify, hey, I have a personal health record, or it goes through my house to get from here to there. But you can, just like with the release of information, go to this Blue Button 2.0 portal and say, my information goes to this other FHIR endpoint, this other health standard API over there. And you don't get to argue with me whether you like that FHIR endpoint, whether you trust that FHIR endpoint, whether it's in North Korea or whatever. Because as long as they're connected via FHIR and it's only my record, it just moves there. And that is the definition of Blue Button 2.0 that I'm pressing CMS for.
And so there's work to be done in terms of moving from where we are today to that vision of what Blue Button 2.0 could be.
Yes, but I want to stress that both Don Rucker and Seema Verma have been very clear so far that that is the direction in which they want to go. And I'm just hoping that people like us are going to hold their feet to the fire to make sure that patients are first-class citizens, and that this does become the basis for a national health data sharing infrastructure.
Very good. Well, that sounds relatively encouraging, I would say.
Yes. You never know until the regulations come out, and you know this much better than me. But so far it has been encouraging, particularly the nature of the way CMS put out this RFI that you mentioned. It was almost as if I'd written it.
Great. Well, Adrian, we're almost at the end of our time together, and in a half a minute or so, I want to ask you my favorite wrap-up question, which is, if you were to wake up tomorrow and find yourself 5 years in the future, what is one thing in healthcare that you would hope or expect to find has changed drastically?
I think the thing that I would think will have changed drastically is that physicians and patients will have examples, real world examples of agency, of technological agency. So even as both the physicians and the patients are now learning about, for instance, artificial intelligence and decision support systems that might or might not be artificial intelligent on day one, but people now are starting to understand that there are situations where the physician's role relative to the patient is subject to decision support, or is subject to artificial intelligence enhancement, that this idea of agency, namely that the patient controls the source of the decision support, the physician controls the source of decision support through their technological agents, begins to emerge, because now these agents are tied to us as individuals rather than being always tied to a particular vendor or a particular institution like a hospital or even the government.
Well, we look forward to that future. Thank you for joining me today, Adrian.
Thank you for giving me this opportunity.
My pleasure. You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.